Hi, everyone. I am Raffy Perez, and I'm here to deliver the lecture on health and how to approach health debates. So I'll just introduce myself briefly. My name is Raffy Perez. I am a third-year medical student at the UP College of Medicine. I'm also representing the UP Manila Debate Circle. So just a brief aside, I recently came out with this paper in the Lancet, and I'm inviting everyone who's interested to learn more about unsafe abortions in the Philippines to look it up because it's a very relevant topic altogether. And it's very sciencey, so you might be interested about this. Anyway, so today I will be talking about health debates. This lecture is not about how to build arguments, and this is the caveat that I want to launch, but rather this is how to approach health debates and what kinds of questions you may be asking whenever you encounter a health motion. So this is the outline. First, we'll go through some definitions, and then we'll talk about bioethics, then the components of health systems and other topics that might be of interest when it comes to health debates. Again, for more in-depth techniques or styles on argumentation, please refer to the dedicated lectures for those as well. So first, let's start with definitions. So according to the World Health Organization, health is the state of complete physical, mental, and social well-being. And the important distinction here is it's not merely the absence of disease or infirmity. And what we like to discuss usually in terms of health is the social determinants of health. So even if, for example, you're able to cure someone who has pneumonia or has an infection of the lungs or airways, it doesn't end there, or the treatment does not really end there, because if they're impoverished and they go back to a very environmentally unideal situation, then it's likely for them to also have that sickness again. So it's important to take into account those social determinants in terms of discussing what treatments are effective or what treatments are applicable for certain patients or certain members of the population. So that's the general definition of health. In terms of debates, they usually revolve around these bullets. So they usually talk about health policies, what to do in times of pandemics, for instance, or what governments should be enacting as policies in terms of healthcare, in terms of medicine. These debates also look like, or usually take the perspective of doctors, whether they should perceive medicine to be in one way or another, or whether the government is justified in mandating doctors to do X, Y, or Z. Those are also things that arise in debates. But lastly, and this is a bit where the distinction becomes tricky, health debates usually intersect with science debates in that there's a lot of health innovations or discoveries in terms of biomedical research that are heavily reliant on scientific principles, but at the same time also account for health principles. So it's important to be wary about that intersection. Therefore, in my opinion, or in my perspective, health debates tend to be very flexible. It's going to be good if you have a matter about the topic. But yeah, that's essentially what health debates are for me, or what health is generally. How do I tend to approach health debates? And so here are just like buckets of arguments that you can choose from or that you can make arguments out of. One of the first things that usually arise in health debates would be the bioethical principles, or of course, the moral justifications for certain treatments or certain actions. And then there are also a lot of pragmatic impacts or pragmatic arguments you can derive out of the components of the health system. But the third bullet, and I want to emphasize this, you can also run other themes in health debates usually because they exist in the real world and have real world applications. So we can talk about things like economics, politics, or even gender or movements. But I want to stress that most often than not, Edge course would be setting health debates because they want the health arguments to arise or to be discussed. So it's important to prioritize those health arguments first. And of course, it's to integrate. So this is not the correct order or the correct sequence of coming up with arguments for health debates. Obviously, sometimes you might think of the other themed arguments first before the health arguments. That is completely valid. But it's just important to, again, weigh and justify why that is the approach that you took in your speech or in the round in particular. So it's in terms of meta, right? Why is it important to talk about this first over another thing? All right, so let's start with the first big bucket of arguments that you can draw arguments out of, and that is the concept of bioethics. These principles come from the textbook by Childress and Beauchamp, and it's not necessary for you to read the entire book, but it's just good matter to read up on if you have the time. There are 4 general bioethical principles, and those are autonomy, justice, beneficence, and non-maleficence. And the dictum here is because there's a lot to choose from, it's always important to dissect and prioritize. That is, dissect which principles are applicable for your side of the house or for that debate in particular, and then move on to prioritizing which is more important or which is more strategic for you to run. So what is more feasible or what is for you to run, for example, which principle do you have more intuition pumps for, etc., etc. And that goes with any kind of argumentation, really. It's important to prioritize and justify again why that is the thing that you're speaking about or you're discussing over another. So the first bioethical principle is autonomy. It's essentially the right to choose what kind of treatment to undergo as a patient or selecting a choice from a variety of selections or options dedicated by society. And there are a lot of ways to prove why autonomy is important for debates. And these two are generally things that you might hear in debate rounds. The first is because patients or those stakeholders have more information over their bodies or over their health rather than relying on other people or other actors like doctors or even governments. That is why they have the right to choose what is best for them. If it's true that there's a state obligation to fulfill an individual's choice or an individual's desires in society as part of the social contract. But another is in terms of self-defense as well. So we usually afford this if in the context of the birth lottery in which people don't really choose to be born, for example, you must afford them as many choices as possible in order for them to make the best decision. So usually those are things that you might hear as justifications for like why people choose things or why people have the right to choose things. For autonomy in particular, so now that we've covered like why people get to choose things, the next question is how. And importantly, the distinction in the textbook of Childress and Beauchamp is that you need to have informed consent in order to exercise your autonomy. And you are able to exercise this autonomy and you are able to have informed consent if you fulfill the two standards here. So first is you're internally capable. That is, you have a sound mind and sound judgment. And the second is you're void from external restraints. You're not being coerced by other actors that hold certain power dynamics or power imbalances against you. So those are the standards by which you are able to say that you have informed consent and you are able to exercise that right to choice. So usually the issues that arise in terms of debates that focus on autonomy are things like, number one, is the choice going to be legitimate or is it going to be informed? So obviously teams will spend time discussing whether you fulfill that internal capacity or that lack of coercion, those two metrics. And it's up to you how to argue those or whether or not these exist. And the next question then is, given that you provide the choice or given that you prevent people from having that choice, will this action lead to better outcomes in terms of the health of that person, in terms of the societal ramifications of that certain action? So those are generally the considerations that would be on my mind when I think about autonomy as a principle. So let's take this example to apply. So this house would allow terminally ill patients to access drugs which have not passed all stages of clinical trials. This is a very classical medical motion. So in terms of clinical trials, there are usually like 3 or 4 phases of it that you must undergo. So it's very arduous. It takes years and it takes a lot of research, a lot of resources as well to fulfill before a drug comes to fruition or gets released to the market. So in terms of autonomy here, you really take the perspective of terminally ill patients. And of course, for government, you have to argue that they are able to make those decisions. Whereas for opposition, you might want to argue that they're not able to make rational decisions. And then you can proceed to talk about why states have an obligation to either provide them this option for gov or really not provide them this option for opposition, and talk about risks in terms of potential harms to these kinds of patients, to the terminally ill, for example, whether it is justified to make them social battering rams for these experimental drugs. So that's one way to apply autonomy in a medical debate. The next biomedical or bioethical principle is justice, which is a very social or societal principle if you look at it. And the definition is the same. So it's really just the equitable distribution of something, or in this case, treatments to people who are deserving of them or are in need of them. So there's a lot of question here in terms of priority. So this also deals with the appropriateness of medical responses, especially in terms of pandemics, whether certain quarantine protocols are effective or are appropriate in terms of catering to the most vulnerable populations. So again, we'll go through the questions or issues. So here, we usually discuss the obligations of different actors. Obviously, if they are not able to fulfill those obligations, and it violates the justice involved in delivering healthcare. So usually the obligations exist in states or in medical communities. Sometimes you will see it in privileged communities as well in terms of giving back or redistributing that level of healthcare delivery. We'll also talk about accessibility here because obviously if drugs or treatments are inaccessible, then this violates healthcare delivery for individuals, and that also violates this principle. But lastly, again, just to reiterate for the millionth time, it's prioritization. So which members of the population should be prioritized first? Or should there be a prioritization in the first place? Or should people receive things generally equally? Those are questions or issues that might pop into your mind when you talk about justice. So again, let's run with an example motion. This house believes that the West should heavily invest in research regarding neglected tropical diseases. So intuitively, of course, government will run things about colonialism, why the West has an obligation to push on the diseases in their neo-colonies, especially when they've pillaged the resources or they've benefited their healthcare system out of research also from these kinds of countries because of the kinds of novel treatments or cures that can be sourced from endemic plants or from traditional medicine, for example. So that's how Gov would say that this is justice, whereas opposition, of course, will try to rebut this and say that it's not really justified as the research that the West puts into diseases that are not from the tropical regions, that is diseases in terms of chronic illnesses like hypertension or diabetes, are also equally valid. And you also remove justice in terms of curing those in developing countries or in the neo-colonies of the West if the investment is prioritized towards only one form of disease. Essentially, might clash that prioritization or like heavy investment should not exist and should be equal. So that's how generally teams might strategize under the principle of justice, especially in debates that call for it really. All right, the next two principles, what people call or what scientists or ethicists call as sister principles, because they're two sides of the same coin. And it's also counterintuitive because these two principles dwell on the pragmatic side of things. But yeah, they are important to mention. So the first is your beneficence, which essentially just says that healthcare's intention is to do good for patients or stakeholders, and that all kinds of treatments or all kinds of innovations or policies need to account for that, need to improve the quality of life or the health of individuals. Whereas the flip side of it is non-maleficence, that states that healthcare should never harm an individual. And the distinction there is, even if you don't do anything or you neglect your duty, then that is also a harm for patients, because obviously certain risks come with non-action as well when we talk about medicine. So the issues that usually arise in these sister principles would look like what the degree of the benefit or harm would look like, how you optimize or minimize the impact. So of course, if it's a benefit, how do you make it better or how do you optimize it? If it's a harm, how do you minimize it if it's really unavoidable? And finally, who is the stakeholder that you want to benefit and why? So again, it's a matter of prioritizing or defending that prioritization in the first. All right, so the example here would look like this house welcomes genetic editing without restrictions. Another classical health debate. So obviously, if you want the perspective of beneficence, or actually these two sister principles, for government, you will be talking about how the benefit overrides the harm in that a lot of genetic diseases or congenital disorders might be eradicated precisely because of this technology or this genetic engineering. And essentially, you want to really paint the stakeholder here. That is the people who are afflicted with congenital disorders either expire or die off very early, or they live lives that are filled with suffering as well. So that's how you frame it, as a technology or a treatment that really benefits an individual, even despite the harm that it might implicate. Whereas on the flip side, if you're opposition, you might want to run an argument about eugenics and how you discrimination against people with these kinds of diseases in status quo, and how that is a much more harmful reality rather than the potential benefit. Of course, you also want to run in terms of the disparities in healthcare, the rich people being able to access this first before poor people. Those are arguments that will be valid in terms of discussing beneficence and non-maleficence. Connected to these two sister principles is the principle of double effect. So the reason why it's connected is because this also deals with the pragmatic ramifications of healthcare or of treatments or approaches in health. So the principle of double effect simply states that actions that cause harm may be permissible if and only if the harm is a side effect of a greater good to be achieved. That is, if the harm is not the intention of the treatment, then it is something that can be permissible, even if it causes a harm. Yeah. So for example, when we talk about Good Samaritans, so let's say in emergency situations, a patient does not consent or is unable to consent to a certain procedure. So for example, for religious purposes, a patient might not be allowed to have a blood transfusion, but in emergency situations in which the doctor does not really know this information, or the doctor decides to proceed with the transfusion because it's life-saving, then you, by the principle of double effect, despite the religious harm that you might implicate because it is life-saving and because the doctor did not have perfect information about the context of the patient, then it is allowable for them to proceed or to have done that certain procedure. So that's essentially the principle of double effect. So in general, what's tricky is, again, a lot of principled argumentation, and this is not exclusive to like health debates. Usually they all apply to both sides of the house and in all circumstances. It's pretty tricky to decide. So for example, let's take the motion, which is relatively new. This house supports human challenge trials. So when we talk about challenge trials, these are clinical trials that deliberately infect an individual with a disease. And so there was discussion in the COVID pandemic if it's valid to pursue challenge trials because of the urgency and because of the high levels of morbidity and mortality that we were seeing during that time. So that's why it became such a large issue. So for government, so actually we'll go through the principles and how they might be differentially argued for both sides of the house. In terms of beneficence, Gov might argue that human challenge trials means that we get better data, real world data, because you observe humans directly, which means that you are able to get better treatments or better vaccinations. So you might argue that the data is not really representative because what happens in real infections, that is in the community setting, usually differs from the challenge trials that exist in controlled environments like a laboratory. The beneficence isn't really effective, or the kind of data that you receive is non-representative. So for non-maleficence, Gov might argue that there are great side effects to this, but at the same time, it still is overridden with the potential benefit of getting a vaccine. And the side effects aren't really the intention of the challenge trials in the first place. That's why it's still justified. Whereas for opposition, it's just going to twist this and say that it's actually malefic because the risks are very unknown and it's going to be hard to have safety nets for individuals who enroll themselves in HCTs. For autonomy, Gov will say that people really consent to it, and usually they have Samaritan or philanthropic reasons for enrolling themselves in risky clinical trials. That's why it's justified, because they have information, like education is possible. Whereas for opposition, in terms of autonomy, they're going to argue, or they might want to argue that the same, there are unknown risks, which means that people can never really get perfect information. Hence, they can't really say that they weren't coerced or that they were really internally capable of making that rational decision. Finally, for justice, Gov will say that having quick treatments expedited means that you are able to deliver health to those who are vulnerable, those populations who are marginalized, and those who need this the most, especially in the long term. Whereas for opposition, the angle for justice is a bit different, and that is you can argue about who the individuals will be. There's one way to argue that it is going to be the marginalized individuals who will undertake this kind of unknown risk in the first place, and that in itself is unjustified. But yeah, the main point of this slide is to really highlight or emphasize the need to fully dissect a certain motion and apply the principles that we just talked about. And then after that, prioritize which is the most compelling for your team to run. That's in terms of strategies. In my perspective, the opposition team in the previous motion would probably pick the non-maleficence argument, or saying that there's a lot of unknown risk to human challenge trials as their launching pad for all of the violated principles that we discussed earlier. All right, so now we're done with principles. Another large bucket of arguments that you can choose from in terms of approaching health debates would be components of healthcare systems. So obviously, the way that health is given to people is an entire complex process. So it's important, or it's useful to break it down into smaller building blocks. So the first would be governance. So this, of course, includes the health policies in terms of what governments do, how they allocate resources, and how they make decisions, or who makes decisions in terms of health and what the priorities are. Second component is your financing. Obviously, this costs money because you have to produce them. You have to get the raw ingredients and transform them using technology into the drugs or the pills that people take in order to get better. The third component would be your service delivery, which includes things like acceptability of the drugs for the public, or even accessibility or affordability, or essentially the provision of healthcare or the provision of those drugs, given that they're already produced or given that they're already made. The fourth component is human resources, or who administers healthcare. So this includes doctors or all of your healthcare workers, and the process of getting good doctors. So it's in terms of retention or even recruitment during different situations. The fifth is information system. So now that you have been able to deliver that healthcare because it's been financed and there are people who are able to administer it, you have doctors, what is next? So you have to also survey or have surveillance about what the outcomes are. Are the treatments effective for certain populations over others? And essentially how information is passed between different components or different stakeholders in your health system. And finally, of course, your medicine. So how do you get effective medicines or better drugs? Are there good alternatives to this? Or what happens if one drug is unavailable over another? So essentially, it's the end product of the healthcare system in and of itself. So those are like the components that you can inspect and analyze. The next slides will just raise questions about how you might want to approach these components and how you might want to build arguments out of them. And we'll just take one motion for this one. And that is this house with decentralized healthcare. Again, another classical health debate. Decentralization essentially means that the decisions on healthcare, instead of relying on a central government, would now fall on the local communities for them to decide. So for example, in the Philippines, this is what we're doing. The decisions rely on the local government units like your barangays or even your provinces instead of a centralized Department of Health. So that's the context. So for example, if you want to argue governance, you might want to argue this in terms of accountability. Is a decentralized healthcare system accountable, or how they are going to be accountable? Or for opposition, of course, why is a centralized government much more accountable or much more like open towards criticism, for instance, or decisions or listening to the masses? And then in terms of governance, of course, the prioritization will always be a constant topic. Will there be a preference for urban communities versus rural communities? And what is the nature of that decision making? Finally, in terms of equitability as well, are centralized healthcare systems benevolent? Are they equitable in terms of providing to the most vulnerable first, or providing enough medicines for them? If you want to argue about financing, secondarily, of course, financing is important in terms of money, in terms of the flow of the resources. You can talk about funding being enough in terms of prioritization again, because the budgets might be decided differently in centralized versus decentralized health system. That's also in terms of prioritization. So which budget cuts would you be willing to undertake for both sides of the house? Medical tourism might be an issue that arises. So medical tourism is essentially going to an area or a location specific for medical services. Usually it's richer individuals from developed states going to developing countries with cheap and accessible medicines like Thailand and other countries in Asia. So that might be an issue as well in terms of the business aspect of medicine. And finally, of course, accessibility. So this also arises in contexts or in clashes wherein the public funding versus private funding clash exists, which might also arise in decentralized healthcare versus centralized healthcare. Is there more likely price hikes in either side of the house? Is there more likely private encroachment if you are decentralized or if you are centralized? So those kinds of discussions will, in terms of the financing bucket. All right. In terms of service delivery, of course, again, going back to the explanations earlier, you can ask questions like, is a decentralized healthcare system much more accessible in terms of medicines? Will people be supporting the treatments that you provide in decentralized healthcare? Will people go to the health centers in the first place? And even will health centers be built very effectively in the first place? So those kinds of questions might arise. So service delivery isn't just about giving the healthcare itself. It's also about whether the infrastructure, the roads, the hospitals, the beds, and the health centers are going to be prioritized, or discussions about whether or like where those things will be better off. In terms of human resources, again, you can talk about recruitment or retention. So there's an inspection of status quo, whether doctors really are motivated to go to your decentralized healthcare facilities, or are they concentrated in urban centers? So where do you change the incentives that doctors have in terms of going to certain areas of the state? And of course, that is deployment as well. So is it justified for states to like force doctors or force healthcare workers to certain areas over in the context of pandemics or in the context of health crises? And how do the system of having a centralized versus a decentralized healthcare system going to impact that kind of decision making? Finally, these two components. So in terms of health information, again, data gathering is very important for the census of a country, because that is also where funding for prevalent diseases relies on. So will surveillance or data gathering be much more effective? If it's a decentralized state, of course, the resources might be limited because you have more limited budget because the onus of control is smaller. But if you're a centralized healthcare system, then it might also be hard because of the level of bureaucracy exponentially increasing or being exponentially harder to account for, because there are more levels for you to report on there. The health information also revolves around health policies, or educating people about the health policies and why people must follow them, especially for quarantine protocols, for example. So is the transfer of information and education something that's going to be better in decentralized healthcare systems or in centralized ones? So finally, we talk about medicines. So mostly this discussion revolves around research and development. What are the incentives of pharmaceutical companies to produce medicines or to invest in researching cures for certain diseases? And this is where the different kinds of diseases come into play. So it might be good to have a bit of knowledge about what kinds of diseases are more prevalent in certain contexts over others, because that also impacts how pharmaceutical companies think about the kinds of investments that they pursue in states or in status quo. So those are generally how I would build the components. So if you notice, you already have 6 arguments to choose from, and just choose or prioritize which one is most impactful for the case. All right, the next part of this lecture is just to talk about the clinical encounter. By the clinical encounter and the interaction between patients and doctors, because I think a lot of debates that revolve around doctors get tricky for people because the incentives between those two actors aren't necessarily very clear. And they are, for good measure, also because people are very complex. So both doctors and patients are complex entities. We'll first start with patients. So again, patients have different incentives for pursuing a clinical encounter. That is, the reasons for them going to a local health center for a checkup vary vastly from individual to individual. So they might want to get better because they are the breadwinners of their family. They might want to get better. They've looked it up already on Google about what their disease might be. So those kinds of incentives or those kinds of years have great diversity. So in order to streamline discussions about patients, it's important to distinguish again what kinds of diseases they have or different sectors of the population have. And one of the easiest sort of splits in terms of kinds of diseases is that of the socioeconomic classes. So the diseases of the rich, most often than not, revolve around lifestyle diseases because they don't really get infections, they don't really get accidents because they have all the resources to prevent themselves from getting those. They have vaccinations, etc. And they're very safe. They have bodyguards, whatever. So usually the lifestyle diseases include things like hypertension, things like diabetes, or even chronic kidney disease, which are things that you accumulate over time. This also includes cancer, by the way. These are diseases that get worse over time. And again, because the rich more or less have prolonged length of lives, then these are diseases that you usually see in them. Versus the diseases of the impoverished communities, in which they might not have the structures or the privileges that afford the safety that the rich people have against certain diseases. So instead of having hypertension or having diabetes, which in the older, these people would rather or would instead have more infections like tuberculosis, pneumonia, or even trauma like motor vehicular accidents, etc. Because again, of their differences in terms of lifestyle. So those are important distinctions because it will guide you in terms of impacting your arguments when there are clashes about what kinds of diseases or what kinds of treatments governments or certain stakeholders ought to prioritize. So that's the first framework that you can work under. The next framework would be discussing the patient's health-seeking behavior. So again, people have different incentives for this, or people have different levels of health-seeking behavior. So being able to discuss the factors contributing to that, whether patients or people are unlikely to go to a doctor to seek help, would be important. So there's a lot of social dimensions to this, like lacking in education or lacking in access towards these facilities that would also guide you in terms of impacting patients in your arguments. And finally, most especially for debates in developing countries or certain contexts, you can discuss what available medical practices are outside of conventional medicine, like traditional medical practices, like pursuing herbal medicine, for example. And you can discuss the pros and the cons of pursuing those versus conventional medicine, and those are also very classical health debates anyway. But that issue exists because, again, patients are very diverse, and it's part and parcel of being able to understand the rationale that these people have in pursuing a doctor. So on the other side of the table would be the doctors. So doctors are also very complex human beings. So number one, we have very different incentives to enter medicine. So a lot of doctors or medical students want to pursue it because they see a vocation out of it, that they want to contribute to society, to the alleviation of suffering, because it's framed in media as this very glorious pursuit. That's one incentive that's possible. Another incentive that's possible is they really just want to make money, or they want to make their parents proud because their parents are also doctors. So people's reasons for entering medicine really differ, and it might be useful to inspect or to have a baseline as to whether one thing is more justified over another, or whether a certain policy or a certain action accounts for either incentives of people entering medicine. You can also discuss or talk about how doctors and workers address burnout, whether an action from a government, for example, like mandating them to go to a certain area in times of pandemics, whether that increases the burnout and what the impacts of burnout are. So will it mean that there will be less doctors in the long term because it's going to be seen as a very tiring profession? That kind of discussion will always exist in a lot of health debates involving doctors. So in accordance with that, also the question of what their incentives are to stay versus to leave states. But aside from burnout, this also looks like lack of opportunity for growth, because doctors in general or medicine in general is a profession of lifelong learning. So of course, because our understanding of diseases and treatments change every single day, then these kinds of incentives differ as well. Whether or not doctors are able to learn continuously or pursue that outcome depends on how you're able to argue that certain policy in the motion. And finally is also the issue of specialization versus being a general practitioner. So in status quo, doctors have the option of specializing in a certain branch of medicine. Usually there's 4, and that's internal medicine or the diseases of the body. There's also surgery, there's obstetrics and gynecology, which is pregnant people and babies, and also pediatrics, which is children. And aside from having those specialties, you can further subspecialize. So within those 4 things that I talked about, you can pursue other more specialized things. Like for surgery, you can subspecialize as a cardiothoracic surgeon, etc., etc. But doctors can also choose to be general practitioners, which would entail that they have an understanding of all of those specialties, but in a much broader sense. So for general practitioners, you might be aware of the very common diseases that you encounter, regardless of the context. But in terms of the specific management or the specific treatment of those complex diseases, those are things that general practitioners would have to refer to specialists. So by referral, we mean contacting your specialist friend and saying that, hey, I have this patient with this very complex disease, which is outside of my scope as a general practitioner. Can you take care of them? So that's how this issue might be fleshed out. Everything that we've talked about might sound a bit complex, so I invite everyone to look them up if these topics interest you, because there's a lot of insight that you may be able to apply in debates about these clashes. So integrating them, you do also have the chunk of issues or questions accounting for both the patient and the doctor in this kind of relationship. Once they meet or once they pursue getting a clinic together, it doesn't end there. It doesn't mean that the treatment will be delivered automatically. So the first there really is to inspect whether patients would believe their doctors in the first place. The basic argument here is doctors are perceived to be people on a higher level of authority over patients, but that's not necessarily effective in certain situations, especially when patients feel that they're threatened, that their autonomy or their agency as an individual is also threatened by the doctors who just impose things on them. Especially in the context of the post-truth era and the rise of anti-science rhetoric, a large discussion will exist in a lot of health debates about how you combat these negative truths from proliferating, or how do you increase people's belief towards the medical community as well. And of course, the mechanisms to do so depend on how you build the argument. And finally, another note on patient-doctor relations, you also have to discuss why these encounters are important. So not only is it the provision of healthcare, most often than not, these patient-doctor encounters also are the starting point of surveillance studies or certain types of research that helps the state figure out which diseases are prevalent or which treatments are effective for people on the ground. So again, health debates might be a bit complex because there's a lot of entanglement or there's a lot of intersections with each subtopic we've discussed thus far. So it's really up to you to disentangle them and prioritize and dissect. All right, aside from the principles of bioethics, aside from the components of healthcare and the clinical encounter, obviously you can run a lot of other things in health debates precisely because these are usually set in the real world, because they deal with treatments, because they deal with real people. So most often than not, there are also arguments about economics, about productivity, employment, arguments about politics, about backlash from certain sectors or certain groups, or even in terms of gender, whether a certain treatment affects like gender minorities more than it does other sectors, etc. But again, the caveat here is that these are non-intuitive health arguments. And in certain instances, they might take precedence, but most often than not, having the landscape of what the health debate really is necessitates being able to dissect the building blocks or the components of health systems that we talked about earlier, as well as whether or not the motion fulfills the principles of bioethics, because the morality of health debates really stems from those discussions. But yeah, that's another thing that's interesting with health debates. Usually they have a social dimension to them. All right, just to point you towards certain case studies, so you might have examples in the next health debate that you have. These are just a list of states that you can read upon or matter load on when it comes to health. Interestingly, Rwanda is also gaining traction in the health world because of their health innovations. So they've integrated drones in their healthcare delivery system, and there's a lot of R&D about AI in Rwanda. If you want case studies about capitalistic versus socialist health, then you can look up the United States and Cuba. So especially for the United States, where healthcare really is treated as a business model with how they approach insurance policies, most especially, those are like manifestations of capitalistic health. Whereas for Cuba, they are very socialist. So even their medical education is free for people, and they rely on a centralized healthcare delivery system as well. The same for the United Kingdom. The NHS makes all of the technological decisions in terms of healthcare, and the health is also free for people. So if you compare UK versus US, actually, insulin is very free in the United Kingdom, or the cost is minimal because they get it from taxes. Whereas in the United States, because it's really heavily reliant on both the insurance and the pharmaceutical companies, your insulin gets really expensive. And finally, for the Philippines, as we discussed earlier, it's a case study of decentralized healthcare. And also, it's not as evident, but it's really an underlying pathology or disease of the Philippines, in that we're also an insurance-based healthcare system with PhilHealth and even the current policy of universal healthcare. So those are just case studies that you not really should, but you may want to matter load on. Okay, so this is, I guess, the final slide. Just a bit of tips in terms of approaching. First, in fact-checking. Health debates have a lot of people asserting stuff. So fact-checking and reading The Economist or the news, or even getting to know the kinds of diseases that are prevalent in certain states, or again, in certain contexts, like the rich versus the poor, would really allow you to diagnose what the debate would really be asking. And in terms of fact checking or rebutting claims from speakers, if you have the matter, you will be able to prove structurally why something is true rather than just throwing up random examples and calling it today. So that's generally uh, what happens in health debates that I think speakers can spend time on. And of course, finally, you have to practice, you have to expose yourselves to a diversity of health debates, precisely because health as a topic in the debating world is very diverse. It's not just health policy, it's also scientific research. It's also sometimes international relations or even health economics. So being able to get the patterns of those kinds of debates would really help you in succeeding on. So that is the end of the health lecture. Thank you very much for listening up until this point. If you have questions, you can reach me through these modes of communication. And I hope you learned a thing or two about how to approach health debate. Thanks, everyone, and all the best.